Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and the guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Dr. Keuroghlian, would you like to pull up your slides? So while he pulls those up, I would like to introduce you all to our guest speaker, Dr. Alex Keuroghlian. Dr. Keuroghlian is the director of the MGH Psychiatry Gender Identity Program, an associate professor of psychiatry at Harvard Medical School, and co-director of the Harvard Medical School Sexual and Gender Minority Health Equity Initiative, which leads longitudinal medical curriculum development and faculty development in sexual and gender minority health at Harvard Medical School. He directs the National LGBTQIA+ Health Education Center at the Fenway Institute, a HRSA-funded cooperative agreement to improve care for LGBTQIA+ people across the United States. Also, as well as the HRSA-funded and Innovative Intervention Strategies Coordinating Center for Technical Assistance, which is focused on implementing emerging strategies across the United States for people living with HIV. He is also a director for the Senior Elective Clerkship in Sexual and Gender Minority Health and for the Advanced Integrated Sciences course, Sex and Gender Informed Medicine at Harvard Medical School. He joins us today to give a talk on mental health care for transgender and gender diverse communities. So please join me in welcoming Dr. Keuroghlian.
Thank you so much, Amy. Hi, everybody. Great to be with you today and looking forward to today's session. The topic I'll be focusing on is mental health care for transgender and gender diverse communities. We'll talk about the context for various mental health inequities that exist across diagnostic categories within what's called the gender minority stress framework, and we'll describe what that is. We'll talk about how to engage in culturally responsive tailoring of evidence-based clinical practices for transgender and gender diverse people, and we'll describe how to apply strategies for building inclusive, affirming, and trauma-informed environments within healthcare organizations like MGH to optimize mental health outcomes for transgender and gender diverse people. As Amy mentioned, one of my hats is directing the National LGBTQIA+ Health Education Center. We offer education, training, technical assistance, and implementation of health programs and services for LGBTQIA+ people in all 50 states, in DC and Puerto Rico, and increasingly around the world in a number of countries. We have webinars by national experts that are live and then archived and available for free on our website. We have interactive learning modules, best practice guidelines like this one on how to build a transgender health program. We have recordings from our national conferences like our Advancing Excellence in Transgender Health Conference that happened earlier this month. All of that available for free. Please feel free to check out any of these resources at lgbtqiahealtheducation.org. Now, to understand mental health inequities experienced by transgender and gender diverse people, increasingly in clinical care, research, advocacy, policy work, we rely on what's known as a minority stress framework. In this case, specifically a gender minority stress framework. The idea here is that transgender and gender diverse people from early childhood developmentally into adolescence and adulthood experience everyday discrimination, victimization, microaggressions, frank violence, unfortunately at a much higher prevalence than the general population. We know from the FBI that in recent years, one of the populations in the United States with the very highest prevalence of hate crimes is African-American transgender women. So that's the horrific reality that many people are living with. We think of all this as external stigma-related stress. This external stigma-related stress over time can take a toll for many people, lead to in some cases, disruptions in general psychological processes like coping skills, emotional regulation, interpersonal relationships, having certain beliefs that may be protective in the moment, but that can perpetuate distress over time, like believing it's never going to get better, nobody can be trusted, no one will ever love me, for example. And all the external stigma related stress can lead to internal stigma related stress, internalized transphobia, expecting rejection because you're so accustomed to it, and identity concealment to prevent mistreatment and abuse. We think all of this stigma and discrimination is related to what we see increasingly in the research and the literature, which is a higher prevalence of various behavioral health problems among some of these populations, like higher prevalence of depressive disorders, anxiety disorders, post-traumatic stress disorder, in some cases, substance use disorders as a way to cope with all this stress, decreased self-care, decreased engagement in healthcare in many situations, often in the context of a lot of well-earned medical mistrust due to mistreatment that's occurred, and down the road, a higher prevalence of certain physical health problems as well. So this is the gender minority stress framework, and it's important to think of it not just as a gender minority stress framework, but as we'll see, a gender minority stress and resilience framework. The idea that minority stress experiences can be a crisis, but can also be an opportunity for promoting coping skills and more adaptive resilience. There's a diagnosis in the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, called gender dysphoria. And this basically refers to misalignment between someone's experienced or expressed gender and what society expects based on the sex that a person was assigned when they were born. In these criteria, it says, this would need to have been the case for at least 6 months, associated with clinically significant distress, impairment in social and occupational functioning, different diagnostic criteria for children than there are for adolescents and adults. Now, this, in one sense, was a step forward from the DSM-4, the last edition that we had until 2013, where there was a diagnosis of gender identity disorder. And that diagnosis was really used to gatekeep and prevent access to gender-affirming care. So that diagnosis inherently kind of pathologized transgender and gender diverse people and said that there's something wrong with a person for being transgender or gender diverse. We know that that was very harmful and not correct, and we've moved beyond that now to this diagnosis that implies that there's distress associated with having a gender identity that doesn't align with society's expectations based on the sex you're assigned when you're born, and that we need to affirm people's gender identities and increase access as much as possible to gender affirming, say, medical and surgical care. That being said, it's still controversial to have any diagnosis in the DSM related to an oppressed, minoritized population, transgender and gender diverse people. And there's a big move away from this so that we move away from this idea of giving people a diagnosis that inherently implies that there's some pathology there and can be stigmatizing. So we'll come back to that a little later, how people are thinking of moving beyond having any diagnosis in the DSM related to transgender and gender diverse people. Here are some general gender minority stress treatment principles for clinicians that we try to apply across the board. One is to normalize the adverse impact of gender minority stress, particularly for younger people. Folks will often attribute challenges in their lives to personal failings rather than to societal stigma and discrimination. So if we can help people feel connected to that broader strength and resilience in their own community, but also to correctly discern when challenges in their life are actually due to stigma and discrimination and not a personal failing, that can be very empowering. Another component here is to facilitate emotional awareness, emotional regulation, self-acceptance, some of those pathways and mechanisms I referred to in the minority stress framework. And behavioral health clinicians are typically going to be, or mental health clinicians are going to be pros at doing this. The third component is empowering assertive communication. For better or for worse, transgender and gender diverse people have to advocate for themselves in healthcare and in life. So if we can help particularly younger people, but people of all ages, learn how to engage not in passive communication, not in aggressive communication, but in effective, assertive communication to get their needs met, that can be a very effective tool. Restructuring minority stress cognitions. Some of those beliefs I mentioned earlier, like believing it's never going to get better, nobody can be trusted, no one will ever love me. And there was, for example, a public health campaign that started a decade ago called It Gets Better to prevent queer and trans youth from attempting suicide. And that directly addresses some of these minority stress induced beliefs that can perpetuate distress over time. And I think in June of this year for Pride, President Biden recorded his It Gets Better public health campaign video to prevent queer and trans youth from attempting suicide. So that public health campaign to restructure these minority stress cognitions is alive and well. Validating unique strengths of transgender and gender diverse people. It's not all bad, right? This is a population with enormous resilience that's overcome tremendous obstacles, achieved greater and greater integration into the mainstream fabric of US society in just a few short years. This year we had our first Senate confirmed presidential cabinet member who's a transgender woman and who's out, Rachel Levine. So when we help younger people feel connected to that greater resilience of the community, that can be a great source of strength. Fostering supportive relationships and community with other trans and gender diverse folks and with allies as well. We often see this starting online initially when people don't have a lot of local access to visibly out trans and gender diverse peers. Once people receive enough validation online, they'll often feel emboldened to seek out more in-person community and affirmation. Of course, these days, much of community building is happening online anyway due to COVID-19. And affirming healthy and rewarding expressions of gender in our practices. I have patients who are currently exploring their gender identity or expression. They'll be in the waiting room wearing clothing traditionally associated with the sex they were assigned when they were born. They'll come back to the clinical area, change in the restroom. We'll do the session with them, for example, wearing a dress for the first time, process what that experience is like cognitively, emotionally for them. After the session, they'll go back in the restroom, change, and leave the building in the clothing that they came in with. And that's a position of great privilege we have as clinicians to foster a safe space for gender identity exploration, discovery, and affirmation. Now, why does most healthcare not look like that? Well, clinicians don't get this in their formal clinical education in medical school, nursing school, training as psychologists or social workers. So people are often playing catch up once they're in the workforce as clinicians and have patients in front of them who are transgender and gender diverse and don't know what to do to help them. Additionally, clinicians are raised in the same society as everybody else and internalize all the same biases in society against transgender and gender diverse people. So we do a lot of work through our education center to mitigate the adverse impact of clinician implicit bias against LGBTQI+ patients, including transgender and gender diverse patients. We often do this with case-based scenarios. This is a paper we published last year to achieve that and to help people understand and gain control over the ways in which their own implicit bias, which everybody has, could adversely impact communication, rapport, and clinical decision-making with patients. And this creeps into psychiatry as well. Whenever we give talks for audiences of psychiatrists or mental health clinicians around the country, we'll get questions that basically boil down to, how do I know this person is really transgender and that it's not borderline personality disorder or a mental health problem? So we, after hearing that question 40, 50, 60 times or some variation on the theme, we wrote this paper on distinguishing and addressing gender minority stress and borderline personality symptoms. This idea that you may observe certain kinds of distress and difficulty with relationships within a clinical setting, for example, that clinicians will often misdiagnose and misinterpret as symptoms of borderline personality disorder, when in fact these are just manifestations of gender minority stress that are understandable and adaptive even in some cases, and that the pathology isn't in the transgender or gender diverse person in those cases. It's really incumbent on society, the community, and our healthcare practices to become inclusive and affirming, to reduce that distress, to facilitate building strong clinical relationships with and trusting relationships with transgender and gender diverse folks. we work with. And this affects policy too. We did this study looking at across the country psychological attempts to change a person's gender identity from transgender or gender diverse to cisgender. And here's a map from that article. You see there are some trends. The redder the state here, the more prevalence there was of gender identity conversion efforts. And you can see that there are some geographic trends. We didn't choose red and blue for political implications, so you don't need to read into it that way. And we found that 14% of transgender and gender diverse people in the country had been exposed to gender identity conversion efforts in the past, and that was about 188,000 people. That's a lot of people. And we don't call these conversion therapy, even though the popular press sometimes does, because therapy implies it's a legitimate clinical practice, which it isn't. It's in fact quite harmful, as we'll see in a moment. And the reason we did this state by state is because there's a battle state by state happening to pass legislative bans on conversion efforts for gender identity or sexual orientation. And what has happened in some cases is that the state house may pass the ban, which is great. And then the governor will say, well, we don't have conversion, quote, therapy in our state, so we don't need a ban, and we'll veto the ban. That happened in the state of Maine a couple of years ago, for example. So we wrote this and published it to say, this does happen in every state and happens at high prevalence, so we need a ban at the state level. And less than half the states in the US currently have a ban on conversion efforts. Massachusetts just passed its ban in, I believe, April of 2019. So we still have a long way to go across the country. And there are a lot of health disparities. We know from the US Transgender survey of 28,000 people around the country from every state, transgender and gender diverse people reported much higher prevalence of serious psychological distress in the past month compared to the general population. 40% reported a lifetime suicide attempt. That's higher than for any other studied population in the US. And that risk of attempting suicide decreases when people are able to access gender-affirming medical and surgical care. So it's important to think about gender-affirming care as life-saving and medically necessary treatment for transgender and gender diverse people. In fact, the American Medical Association has considered this medically necessary treatment since 2008. And if we look at suicide risk in the US, in the general population, depending on the study you look at, the lifetime prevalence of attempts is 4 to 5%. And lifetime prevalence of suicide attempts for presumed non-transgender or cisgender sexual minority adults is 11 to 20%, much higher than for the general population. But for gender minority adults, it's 40 to 41%, depending on the study that you look at. So much higher even than it is for presumed cisgender sexual minority adults. In the previous year, according to the US Trans Survey, 48% of people seriously thought about suicide, 24% made a plan, 7% attempted in the past year. 40% who attempted at some point in their life based on that study, of those, 34% made their first attempt by age 13 and 92% by age 25. So those of you who work with and are supporting transgender and gender diverse children, adolescents, and young adults are in a position to really save lives and dramatically improve the life trajectory for these young people. We published this study last year looking at the relationship between conversion efforts and suicide attempts. And we found that, like I said, 14% of respondents in the US were exposed to gender identity conversion efforts. Being exposed to these conversion efforts was associated with more than twice the odds of attempting suicide in your lifetime. And exposure before age 10 was associated with more than 4 times the odds of attempting suicide in your lifetime. There's no difference in outcomes with regard to conversion attempts if these are administered by a religious advisor versus a secular type professional like a psychotherapist. So it's not the religious component that's dangerous, it's any effort to change someone's gender identity from transgender or gender diverse to cisgender. And this study we did was then cited by the American Medical Association to when they passed a resolution in support of a federal US ban on conversion efforts, and by the United Nations General Assembly last year when they passed a resolution in support of an international ban on conversion efforts. Another study we published last year out of the US Trans Survey, again, looked at pubertal suppression and risk of suicidal ideation. Pubertal suppression is the use of gonadotropin releasing hormone analogs or puberty blocking medication in early puberty, Tanner stage 2 of puberty, to press pause on development of secondary sex characteristics, because when those characteristics develop, we often see an increase in suicide attempts, unfortunately, among young people. And you do then need to induce puberty in a timely way with, say, estradiol or testosterone, but it's a puberty that aligns with the child's or teenager's gender identity. And these medications are really valuable for that reason. We found that only 2.5% of people who desired these medications were ever able to receive them. And people who did receive them, compared to those who desired them and didn't receive them, had lower odds of lifetime suicidal ideation. So these are really beneficial medications that keep people safe. And unfortunately, there are legislative efforts in many states in the US now to ban access to gender-affirming medical care for minors and to criminalize it in some cases. So the prescriber would go to prison potentially, for example, or to report the parent or guardian for child abuse. So there's a poor understanding and low knowledge fund of these interventions among policymakers, clinicians, and the general public. And we have a lot of education we have to do in that regard. We published this in April of this current year, and this was looking at the relationship between gender-affirming surgeries and mental health outcomes, again, using the US Trans Survey of 28,000 people. We found a few things. First of all, most people who desired these various gender-affirming surgeries weren't able to access them nationally. And these are considered medically necessary treatment, just as a reminder. Additionally, people who were able to access one or more gender-affirming surgeries compared to people who desired gender-affirming surgery and weren't able to access them had lower odds of past year suicidal ideation, past year cigarette smoking, past months severe psychological distress. And Anthony, who did the study with me, did something very clever. He looked at the degree of surgical gender affirmation and found that people who received some of their desired surgeries compared to people who received all their desired surgeries had higher odds of past year suicide attempts, past year suicidal ideation, past year cigarette smoking, past month binge alcohol drinking, and past month severe psychological distress. So we really need to expand access through centers of excellence that can provide these surgeries and more insurance coverage to these gender-affirming surgeries to improve mental health for transgender and gender diverse people who desire them. We published this study this summer, and this was looking at when people in their lifetime developmentally undergo social affirmation, are affirmed in terms of perhaps their name, their pronouns, the way they dress, and so on. And we looked at people who were socially affirmed before age 10, people who were socially affirmed as teenagers, and people who were socially affirmed as adults. And the reason we did this is that there's a big school of, I shouldn't even say school of thought, there's a big push by anti-trans political agenda to do what's called watchful waiting, to say, well, kids can't know what their own gender identity is, teenagers can't know what their own gender identity is, so let's not permit them to be socially affirmed in their gender identity. Let's make them wait until they're adults and then let them make their own decisions at that point. But what we found is that people who were first socially affirmed as children before 10 years old and people who were first affirmed as teenagers had mental health outcomes in adulthood that were just as good as people who first underwent gender affirmation in adulthood. In fact, people who were able to be socially affirmed as children had lower odds of a cannabis use disorder than people who weren't able to be affirmed until they were adults. We did find that the factor associated with worse mental health outcomes in adulthood for people who were socially affirmed as teenagers was school-based harassment. So we need policies to keep trans and gender diverse kids safe and thriving in school, protect them from harassment specifically of all kinds, for them to have the same mental health outcomes in adulthood as anyone else. We've also looked at factors associated with post-traumatic stress disorder. Factors associated with higher PTSD among transgender and gender diverse people included higher everyday discrimination scores, having more reasons for someone attributed being discriminated against. So someone's discriminated against because of their race and their age and their socioeconomic status and their gender identity, that cumulatively is associated with more severe post-traumatic stress disorder. Having a more visually expansive gender presentation, so not blending in visually as a girl or boy or woman or man, is associated with more severe PTSD as well, and experiencing unstable housing in the context of pervasive employment and housing discrimination. Factors associated with lower PTSD included younger age, having a transmasculine gender identity, so being assigned female sex at birth and identifying as more masculine than feminine. And that is probably because we live in a patriarchal society where people are much more understanding and accepting of someone assigned female sex at birth who identifies as more masculine than someone assigned male sex at birth who identifies as more feminine. And accessing gender-affirming medical care was associated with lower PTSD severity as well. Now, there are excellent evidence-based treatments that we can tailor based on a gender minority stress framework to provide more culturally responsive care for transgender and gender diverse people. We can adapt components of cognitive processing therapy. This is an evidence-based manualized treatment protocol. And this focuses on education about post-traumatic stress. It involves writing or verbally, if there's a literacy barrier, writing an impact statement to help understand how trauma influences the person's beliefs about themselves, other people, and the world around them. Identifying maladaptive thoughts, or they're called stuck points in this intervention, about trauma that perpetuate emotional distress over time. Decreasing avoidance, it really kind of conceptualizes PTSD as a disorder of avoidance, where if someone doesn't at some point cognitively, emotionally process traumatic experiences, then that is thought to be what leads to PTSD, and focuses on increasing resilient coping as well. Here's the cognitive triad of traumatic stress from SAMHSA, the Substance Abuse and Mental Health Services Association in the federal government, and focuses on views about the self, views about the world, and views about the future, and how those can all change into more, in many ways, kind of all or nothing thinking that perpetuates distress when people have experienced trauma in their lives. So how would we tailor cognitive processing therapy based on a gender minority stress framework? We can focus on how gender identity specific stigma can lead to post-traumatic stress, can cause avoidance, mistrust, hypervigilance, for example. How transgender and gender diverse people, as I mentioned, may attribute challenges in their life to personal failings rather than to societal stigma and discrimination. So reframing those beliefs to cultivate more resilience and decrease distress. The impact statement that people do as part of cognitive processing therapy could focus on experiences of discrimination and victimization, how these affect a person's beliefs, how they can contribute to expecting rejection, having a need for concealing one's identity, experiences of internalized transphobia, believing all the negative things that society has to say about your gender identity or your gender expression, and decreasing avoidance, which can include decreasing isolation from transgender and gender diverse community members, or avoidance of medical care in the context of some very well-founded, well-earned medical mistrust, given how poorly many transgender and gender diverse people historically have been treated within healthcare. We can also focus on how minority stress experiences may adversely impact an individual's health behaviors and goals, like their desire for gender affirmation, as we'll talk about, like gender-affirming medical care, or adequate adherence to various medications, for example, antiretroviral medication for prevention or treatment of HIV. Word about addictions, specifically among transgender and gender diverse people. I should say that transgender health is generally quite underfunded as a research area, although that's improving because there's an Office of Sexual and Gender Minority Research now at the National Institutes of Health in Bethesda that's ramping up more funding in this area. Reporting of gender identity data and addictions research is quite limited. So we can't go back and look at addiction studies and say, well, what was going on with transgender and gender diverse participants in the study versus the other patients. It's hard to do that kind of secondary data analysis. In the studies that do exist and increasingly are being published, transgender and gender diverse people have an elevated prevalence of alcohol and drug use disorders compared with the general population. One study has found that many transgender people will use substances to cope with school-related verbal or physical harassment, assault, or expulsion related to their gender identity or expression. Studies have also found that people may use substances to cope with the stress of not being able to access gender-affirming standard of medical and surgical care as well. We did a study with 452 transgender and gender diverse adults in Massachusetts, looking at odds of substance use disorder treatment history plus recent substance use, and found that these were associated with intimate partner violence, post-traumatic stress disorder, public accommodations discrimination, meaning discrimination in public parks, in public transportation, housing, facilities, restrooms, restaurants, and so on. And there was a ballot measure during the midterm elections in 2018 in Massachusetts to repeal existing public accommodations protections for transgender and gender diverse people. And luckily, the people of Massachusetts voted to maintain these public accommodations protections that are so important. Substance use disorders in our study were also associated with unstable housing in the context of pervasive familial, educational, employment, and housing discrimination that people experience, and survival sex, or in the context, again, of all this discrimination that leaves people very few options for how to survive. So we really think about any increased prevalence of substance use disorders in this population as a downstream effect of chronic gender minority stress. We did a systematic review of alcohol research with transgender and gender diverse people. And we found that many studies were not explicit about and confused the differential impact on alcohol use of sex assigned at birth and natal sex-based physiology, current sex-based physiology if somebody was on gender-affirming hormone therapy, for example, and social drinking patterns that are gendered in many cases. We know that women and men are socialized to consume alcohol with different patterns. However, those patterns don't necessarily apply if we're assuming everyone is, cisgender and has a binary gender identity when we start working with transgender and gender diverse people. We also found that there was a very limited repertoire of alcohol-related measures that were not contingent on sex and gender assumptions, as we'll talk about in a moment. Many of these existing screening instruments for alcohol use, like the audit, had not been psychometrically tested with transgender and gender diverse populations. And we need to shift beyond cross-sectional study designs just at one time point towards more longitudinal research. We published this paper in December with a great medical student here at Harvard Med School on screening, counseling, and shared decision-making for alcohol use, transgender and gender diverse populations. In one of the tables in that paper, we looked at guidelines for at-risk alcohol use from the CDC, from the NIAAA, official sort of bodies in the US, and looked at guidelines for moderate drinking, heavy drinking, binge drinking, and found that these all falsely assumed people have a cisgender and binary gender identity because the research that they're based on assumed everybody is cisgender and binary. So we call for a shared decision-making approach with patients to say, here are the current guidelines. We know they're flawed because they falsely assume that everybody has a cisgender and binary gender identity, which is not the case. So let's work together to figure out what healthy alcohol use looks like for you. We wrote this piece about opioid use among LGBTQI+ people with another great medical student of ours, and found that a few things. One is transgender students are more than twice as likely to report prescription pain medication use compared to their non-transgender peers. Transgender adults on Medicare have increased prevalence of chronic pain compared to cisgender or non-transgender adults. And we also know that, as we saw, many transgender and gender diverse people pursue gender-affirming surgery as medically necessary treatment. And what do we prescribe most people in the US who have surgery? Opioids, right? So now we have this already oppressed minoritized population with this massive built-in exposure to opioids, which puts people at very high risk for developing an opioid use disorder over time. So we are working now with public health officials and other folks who are in positions to implement a public health approach to mitigate the real risk for opioid use disorder related to that in a thoughtful way. Now, like we did with cognitive processing therapy, there are evidence-based manualized treatment protocols for substance use disorders that we can tailor based on a gender minority stress framework. One example is cognitive behavioral therapy for substance use disorders. This is a manualized treatment developed by Carol, and it focuses, among other things, in the standard modules here on coping with cravings, triggers, managing cues, craving control, shoring up motivation and commitment to not use substances, like clarifying and prioritizing goals, addressing ambivalence about using substances, focuses on cultivating substance refusal skills and assertiveness, so differentiating passive and aggressive responding from more effective assertive responding, developing an all-purpose coping plan that anticipates high-risk situations, and there's a built-in module here already on HIV risk reduction. So how could we tailor this for transgender and gender diverse people? We could focus on minority stress-specific triggers or cravings, like gender identity-related discrimination and victimization, expecting rejection, identity concealment, experiences of internalized transphobia, substance use disorders as a barrier to personalized health goals. I have more luck. I have time in my week where I see people who don't need to see me for longitudinal psychiatric care, but see me for a letter in support of gender-affirming surgery. And I've had more luck getting people to discontinue at-risk substance use because they wanted to have surgery and knew that they needed to stop before surgery because the surgeon wouldn't perform the procedure otherwise, for example, than I have for any other reason. The drive for gender affirmation is so strong that people will do that. And this is sometimes because people want the best possible surgical outcomes. People know that, or will explain to people in this situation, if they're smoking cigarettes, that nicotine is a vasoconstrictor that reduces blood flow, and that will adversely impact wound healing and surgical outcomes. So that will often motivate people to quit smoking, for example, before they have surgery. So that kind of motivation can be incorporated into this existing evidence-based protocol for substance use disorders. And we can focus on things like assertive substance refusal with sex partners. That's a way to tailor this in a more culturally responsive way. It can be very affirming to be accepted in a sexual or intimate context in your gender identity or expression. And that can reduce the power someone has in a dynamic with a partner to negotiate not using substances during sex or using condoms, for example, if it's transactional sex context, even more so. There's also risk of HIV transmission from a specific form of substance use that's pretty unique for some transgender and gender diverse people, which is the use of medically unmonitored hormone therapy or silicone self-injections for body contouring. We see this more in communities that have even less access to gender-affirming medical care, like in Black and Latinx communities where there are a lot of inequities in terms of access to appropriate care. People will have, for example, pumping parties, share needles, which increases the risk of HIV transmission or hepatitis, for example. So these are just some ways to tailor existing evidence-based protocols in a culturally responsive way based on a minority stress framework. Important to note, opioid agonists for maintaining sobriety from opioids like methadone and buprenorphine are safe and totally feasible to prescribe with gender-affirming hormone therapy if you do monitoring and follow-up. And patients will often be very concerned to ensure that any medication you prescribe them doesn't interfere with the effectiveness of their gender-affirming hormone therapy. So you can provide some reassurance here if you're discussing methadone or buprenorphine as medication-assisted therapy for sobriety. A word about eating disorders and body image dissatisfaction. There's a higher prevalence of body dissatisfaction among transgender and gender diverse people than cisgender peers. And there can be a drive for thinness, for example, among both transmasculine and transfeminine people for different reasons. And body dissatisfaction won't just be necessarily for gender identifying body parts, but also for shape and weight in general. And transgender and gender diverse students are more likely to be underweight or obese, less likely to meet recommendations for strenuous physical activity, strengthening physical activity, and screen time. And it's important to always ask people to have a very body positive approach, not make assumptions about how people refer to their body parts. For example, someone may refer to their chest instead of their breasts. So you can ask people what they call their body parts and reflect their own language back with them. In terms of affirming gender identity for folks with serious mental illness, psychiatry and mental health as a field in the past has often kind of been dismissive of people's gender identity and gender affirmation needs, and has in some cases said, let's first get your substance use disorder under control, or your PTSD under control, or your substance use disorder, not just under control, but in remission altogether. Or even worse, has said, I think this person's report of being transgender is a symptom of PTSD related to their childhood sexual abuse, or I think that this is part of their delusions related to schizophrenia. We now know that that kind of thinking or approach is really ineffectual and unethical. We do need to make every effort to stabilize psychiatric symptoms that are present, because those are inherently distressing on their own, and because they interfere with the very important process of gender identity exploration, discovery, and affirmation. The World Professional Association for Transgender Health calls for reasonable control of physical and mental health problems. That doesn't mean remission. That doesn't mean person's asymptomatic. It just means that they have medical decision-making capacity to provide informed consent. So it's an informed consent model. And beyond that, we don't want to engage in any unnecessary paternalistic gatekeeping. As clinicians, we can foster gender identity exploration, discovery, and affirmation. We can present both medical and non-medical strategies for gender affirmation that can include chest binding, genital tucking, changing the way you dress, changing the gender markers on official government-issued documentation, changing your name and pronouns, of course, assisting people in making fully informed decisions about how to personalize their gender affirmation process. Not everybody wants hormones, not everyone wants surgery or every possible surgery that's out there, discussing risks and benefits. And our primary care colleagues may ask us as mental health clinicians to help them evaluate capacity for medical decision-making and obtaining informed consent in situations where, for example, with serious mental illness, primary care colleague may not be sure if they're able, how best to elicit informed consent. And arranging suitable referrals for care as needed. It's a very interdisciplinary approach. We can focus on reducing internalized transphobia, helping improve body image, even while we're making every effort to support body modifications. We want to check in about people's expectations maybe for how hyper-masculinized or how hyper-feminized they're going to be at the end of that process, so that people feel as comfortable in their skin as possible as they've gone through these gender affirmation steps. And particularly for younger people, but really everybody, to facilitate adjustment, thinking concretely through different domains of a person's life that may be affected by gender affirmation. That includes physical changes that may occur, psychological changes, social dynamics that may evolve, changes in libido or fertility preservation can be an important piece, and then economic and legal challenges that may arise. Finally, I mentioned that there's a big push away from giving people a diagnosis of any kind who are already part of an oppressed, minoritized population, and moving away from this diagnosis of gender dysphoria that's currently in the DSM-5. And we wrote a piece about this last year in the British Journal of Psychiatry. This idea of uncoupling gender diversity from the inherent stigma of diagnostic classification in clinical practice, moving towards non-diagnosis codes like Z codes in ICD-10 or Q codes in ICD-11 that can code and bill for something like factors influencing health status and still allow reimbursement by third-party payers. We can seek reimbursement for services without a particular diagnosis needing to be assigned, like these surgical evaluations I do. Why couldn't I bill for psychiatric evaluation preceding gender-affirming surgical intervention without giving a diagnosis that implies there's some kind of pathology or distress, which isn't necessarily the case? So it's very exciting to see this rights movement for trans rights be so aligned with progress in terms of how we think about healthcare practice and policy. With that, I'll stop. We're right about the 15-minute mark. I very much appreciate your time, and I look forward to our discussion and any questions you all may have.
Thank you so much, Dr. Keuroghlian. We are now towards the end of the session. So if you have any questions for Dr. Keuroghlian, feel free to enter them in the chat box. So I do see a question. How do you handle mistakenly addressing someone by the incorrect gender?
Great question, and this comes up all the time. And everybody at some point probably makes mistakes in terms of misgendering a person. Even transgender and gender diverse folks will make mistakes, in terms of misgendering others. The most important thing to do then is to apologize sincerely and correct yourself. To say, "I'm so sorry, I didn't mean to be disrespectful," and correct yourself, whether it's pronouns that were incorrect that you used, and showing that you're doing that. That's a great way to diffuse a difficult situation and reestablish a constructive dialogue. Now, it's really important to try to not get flustered in that situation and dwell on it, and try to convince them that you love watching Pose and have a transgender uncle. You don't want to center your experience, because that'll just make them feel more uncomfortable and awkward. So just say, "I'm so sorry, I didn't mean to be disrespectful," and correct yourself and move on. And that's a way to kind of be as considerate as possible of the person. So thank you for that question.
Thank you. So do you know what Mass General is doing? Like, what are current efforts at Mass General? Any programs, services, or efforts available to support our transgender and gender diverse communities?
Yes, absolutely. We have several programs in a number of departments at MGH. In our psychiatry department, I direct our psychiatry gender identity program that we started 3 years ago now. And we've placed hundreds of transgender and gender diverse people in care through that program. We have several dedicated psychiatrists in that program, and psychotherapists as well. And we see people across the lifespan. We see young children, adolescents, and adults of all ages. There's also a transgender health program within Department of Medicine and Pediatrics that provides primary care for adults, and pubertal suppression and hormone therapy for adolescents. We have surgical programs now in plastic surgery, OBGYN, and urology that perform basically the full range of gender-affirming surgeries, including genital construction surgeries, facial feminization, facial masculinization, chest construction surgeries, and so on. And
Thank you.
it continues to grow. We have a lot of people signing up for care at MGH.
Are any special training available for staff?
Yes, absolutely. Well, I would recommend a couple of things. We have many free trainings at the National LGBTQI+ Health Education Center that I direct, which is here. So please feel free to check out trainings in all specialties in all areas of transgender health at lgbtqiahealtheducation.org. In fact, we have an annual Advancing Excellence in Transgender Health conference, and we just held that this September 30th through October 3rd. We had people attending from 44 US states and from the Philippines, Saudi Arabia, Iraq, the Netherlands, Canada, Barbados. We've had people from Korea, Japan, many places attend each year. It was our 7th year doing it. And we record those sessions, and they're available for free now on our website as well. So it'll keep you busy for a very long time if you want to learn on our website.
That's great. And for anyone who's tuning in, if you need links to those websites, feel free to email the Blum Center at pflc@partners.org, and we'd be happy to share those resources with you.
Thank you, Amy.
Okay, so we have another question that came in. When a patient is using she, they pronouns, does that indicate she and they can be used interchangeably?
The short answer is yes. And as you can see, my pronouns are he and they. So what that indicates is that I'm perfectly comfortable with he or they pronouns, and that people can feel free to use either. And this comes up quite a bit when people have two pronouns they give. If one is the one that should be used. Typically, if there's a pronoun someone doesn't want you to use, they won't list it. So if they're listing both, it means that they're comfortable with both, and you're welcome using either. Thanks for asking.
Thank you. Okay, so we'll give it another minute to see if anyone else has any questions. In the meantime, Dr. Keuroghlian, do you have any final thoughts you'd like to share with the audience?
Really appreciate you all joining and taking an interest. We all continue to learn together, and it's an exciting field that is growing very quickly and is just in its infancy now, is already something with major societal implications. It's something we see, in the news every day in terms of human rights nationally and internationally, and it's a wonderful field for any staff at MGH or beyond to take more of an interest in and get involved in, because there's so much need. There's so little access to affirming care. So I appreciate each of you wanting to learn more and be more affirming in your work and in your personal lives and communities as well.
For those who are not staff joining today, is there any way for us to become involved in our communities?
Absolutely. I think learning just personally how to engage in sensitive, effective communication, like some of the great questions asked, goes a huge way. Thinking about your own implicit biases I talked about, and the ways in which even those of us who identify as LGBTQI+ or who identify as transgender and gender diverse are raised in society and have our own internalized transphobia or internalized homophobia that we just have to be aware of and continue to work on. It's a lifelong process. You're never done with it. And I also invite anyone to get involved in political advocacy and being an ally. And that includes things like, writing your congressperson to support a ban on conversion efforts if there isn't one in your state, or getting involved in advocacy efforts to prevent these bans that would criminalize provision of gender-affirming medical care that's evidence-based for transgender and gender diverse youth. So there are many things people can do as citizens if they're not even, if they're not working in healthcare.
Thank you so much. And as I mentioned earlier today, this session is being recorded. So if you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, Dr. Keuroghlian, for a wonderful presentation. And thank you so much, everyone, for joining us today. Hope you found it helpful. Have a lovely rest of the day.
Thank you, Amy.